Hello friends, today we'll be discussing about the joints of the lower limb. This is Dr. Yusuf signing from Al University, Saudi Arabia. The specific objectives for today's topic is describe all the joints of the lower limb, mainly the bigger joints, regarding their articular surfaces, capsules, ligaments, synovial membranes, bursae, relations, nerve supply, movements, and muscles responsible for each movement, the stability of the joint, as well as the applied aspects related to the specific joints. So this is the objective for today's topic. To begin with, before we discuss about the joint itself, we are supposed to know the classification of joint. There are many different types of classification. One of the type of classification is the structural classification. The structural classification, in this, the first type of classification is the fibrous joint. Fibrous joint are again of three types: the sutures, the syndesmosis, and the gymphosis. Then we have the cartilaginous joint, which are of again two types: primary cartilaginous joint as well as the secondary cartilaginous joint. The third and the most important will be the synovial joints, and the most commonest among them will be the ball and socket type, or it is also called as the spheroidal joint. The second type of synovial joint will be the cellular or saddle type of joint. The third is the condylar, or it is also called as the bicondylar joint. And the fourth type is the hinge joint. The fifth is ellipsoid joint. Sixth is the pivot or the trochoid joint. And the seventh will be the plane joint. This is the classification of the joint. Now we'll study each joint which is there in case of the lower limb, and we'll try to see in which classification these joints will fit. To begin with, we'll talk about the hip joint. The hip joint is a synovial joint, so it comes under this classification here. It is the ball and socket type, or it is also the spheroidal joint. So it is ball and socket type, and it is a multi-axial joint. So the movements here will be in the different direction, with articulation between the head of the femur and the acetabulum. So this is the head of the femur here, and this is the acetabulum. Compare this again whenever you discuss about the joints. You should compare these joints with that of the upper limb. Compare this hip joint with that of the shoulder joint. There also we have the head of the humerus articulating with the glenoid cavity. Here similarly we have the head of the femur articulating with the acetabulum. So because there is articulation between the head of the femur and the acetabulum, so this is also called as the acetabulo-femoral joint. The articulation between the acetabulum and the femur, so it is called as acetabulo-femoral joint. In case of the upper limb, in case of the shoulder joint, there is maximum mobility at the expense of the stability. So in case of shoulder joint, it is very mobile joint, but the disadvantage of having excessive mobility is it is more prone for the dislocations, and so it is less stable. But compare this with that of the hip joint. This is more stable joint. This has maximum stability, so at the expense of mobility. So the range of movements here, even though all the movements which are taking place in the shoulder joint also take place here in the hip joint, but the range of movement is decreased. So this is the consequence of having more stability. If you have more stability, then there are movements, but the range of movements will decrease. So this is how the hip joint differs from that of the shoulder joint. If you see the articular surfaces of these joints, so the articular surfaces, as you have already seen, it is between the head of the femur and the acetabulum. in the acetabulum, if you can see here, not everything is articular here. The part which is articulate, so this is called as the articular part, and there is non-articular part. So the articular part is also called as the lunate surface. This is the lunate surface, and here there will be a notch. This is called as the acetabular notch, and this is covered by a ligament called a transverse acetabular ligament. So this is the lunate surface, which is the articular surface, and there is non-articular surface. This is called as the acetabular fossa, where we can see the attachment of the ligament of head of femur from the fovea of the head of femur to this acetabular fossa. We can see the ligament of head of femur. So this is non-articular part here, which is called as the acetabular fossa, and the articular surface of the acetabulum, that is called as the lunate surface. Okay, and the acetabulum is increased in its size by something called as the acetabular labrum. This is nothing but the fibrocartilaginous structure which extends at the margins of this acetabulum, and it increases the size of the articular surface. If you can see here, this is the acetabular fossa, and there is an increase in the size of the acetabular fossa by the presence of something called as the acetabular labrum. Similarly, we have in case of the shoulder joint, there is also the acetabulum, the labrum there around the glenoid fossa, that will be called as the glenoid labrum. Here it is, because it is attached to the acetabulum, so it is called as the acetabular labrum. This is nothing but the fibrocartilaginous tissue which is surrounding and increases the surface area for the contact with that of the head of the femur. So it increases here on all the margins of the acetabular part, which is articular. So this is called as the acetabular labrum. Then we have the outside this, we have the synovial membrane. Because this is a synovial joint, the whole of the cavity, inside cavity, will be lined by synovial membrane. So the whole of this cavity is lined by synovial membrane, except you should remember that it doesn't line the articular surface. So it is not on the head of the femur nor on the articular surface of the acetabulum. Apart from that, everywhere there will be synovial membrane. You can see here, this is the synovial membrane cut, and you can see if this cut margin is joined, then it will join here directly. So it doesn't cover the articular surface of the head of the femur or the acetabulum. This is in case of all the synovial joint. Synovial cavity, the whole of the joint cavity is lined by the synovial membrane except the articular surface. So what is this articular surface will be covered with? This articular surface will be covered by the articular cartilage. So this articular cartilage will be covering this part of the articular surface, that is nothing but the hyaline cartilage. That's why it is shown in bluish color. So this will be lined by the hyaline cartilage. So here you can also see here, this is the same synovial membrane covering the whole of the hip joint. You can see here the line of attachment of this synovial membrane. Outside this will be the fibrous capsule. If you can see here in this picture, here you can see outside this synovial membrane is the thick fibrous capsule. So these are some of the important structures which you are supposed to know in the hip joint: articular surfaces, the acetabular labrum, the synovial membrane, as well as the fibrous capsule. Now I said this joint is a very stable joint. So this joint is stabilized by the very important structures, which are nothing but the ligaments, which will stabilize the joint to a very large extent. So what are the ligaments which are here in the hip joint which will stabilize this joint? One is the fibrous capsule, which is outside. You can see here, this is the fibrous capsule, which is also called as the capsular ligament. Then we have three important ligaments which will be the main ligaments which will be holding this joint in a very stable way. Okay, as you know, there are three parts of the hip bone. So this ligament will be also having three parts, or the three separate ligaments which are coming from the three different parts of the hip bone. So the hip bone is made up of three bones: the ilium, then we have the ischium here, as well as the pubis. This is the ilium, This is the ischium and the pubis. So there are three ligaments which are running from each part. One ligament, if you can see here, which is running from the ilium to the femur. This is called as the iliofemoral. So this is a ligament which is running from the ilium to the femur. So it is called as the iliofemoral ligament. This is the in the front. If you can see from the front, then you can appreciate this ligament called as the iliofemoral ligament. If you see from behind, there is one ligament running from the ischial tuberosity. This is the ischium here. So near the ischial tuberosity, the ligament which runs from the ischial tuberosity again to the femur. So this is called as the ischiofemoral ligament. And there is one ligament which is running from the pubis to the again to the femur. So this is called as the pubofemoral. So here will be the pubofemoral, from which is running from the pubis to the I can see okay, here you can see, here we can appreciate here, this is coming from the pubis and going to the femur. So this is called as the pubofemoral. This is the iliofemoral, and behind, if you can see, it will be the ischiofemoral ligament. So there are three ligaments which are very important ligaments of the hip joint. Those are the iliofemoral, pubofemoral and ischiofemoral, coming from the three parts of the ilium, ischium and the pubis of the hip bone and getting attached to the femur. So these are called iliofemoral, pubofemoral, ischiofemoral. These are the very important ligaments which help in the stability of the hip joint. Apart from that, there are also the secondary ligaments, like the ligament of the head of the femur. You have already seen this is the ligament of the head of the femur running from the acetabular fossa to the fovea of the head of the femur. Okay. So the importance of this ligament is, even though it is secondary, there is an artery which is running through this. This is called as the artery of the ligament of the head of the femur. So this is an artery branch from the obturator artery, and it will be supplying mainly this will be supplying mainly a small part of the head of the femur. Okay, so this is the ligament of the head of the femur, which you can see here also getting attached from the head of the femur, fovea of the head of femur to the acetabular fossa. The secondary ligament is the acetabular labrum itself. We have seen the labrum, so this also help in the as a ligament, and it also helps in the stability of the hip joint by increasing the surface area of the contact. Okay. Then there is also a third secondary ligament. This is called a transverse acetabular ligament. So if you can see here, I said this is the lunate surface. Here this is called as the acetabular notch. This notch is converted into a foramen called as acetabular foramen by the presence of a ligament. This is called as the transverse acetabular ligament. So this ligament also help in the stability of the joint, but to a lesser extent. The main joints, the main ligaments will be the iliofemoral, pubofemoral, ischiofemoral, along with the fibrous capsule. The secondary are the ligaments of the head of femur, acetabular labrum, as well as the transverse acetabular ligament. So these are some of the ligaments which help in the stability of the hip joint. There are also other factors which help in the stability. So we will now try to study all the factors which help in the stability of the hip joint. As I said before, it is a very stable joint, and there are some important factors which help in the stability. One is the deep acetabular fossa. If you compare this with that of the shoulder joint, remember the glenoid fossa is a very shallow fossa, and it is very small compared to the head of the humerus. Head of humerus is 3 times larger compared to the acetabular fossa. But in case of the and it is very shallow. But in case of the hip, you can see this is much more deeper. The acetabular fossa is much more bigger, larger, as well as it is much more deeper. So this help in the stability of the deep acetabular fossa, help in the stability of the hip joint. Along with that, the extension of this acetabular fossa by the presence of the labrum, that is the acetabular labrum, increases again this depth of this cavity as well as the size of the articular surface. So this acetabular labrum also increases the helps in the stability of the hip joint. Apart from that, there is a negative vacuum effect within this hip joint, which pulls the two bones, the acetabular fossa and the head of femur, because there is a vacuum pressure within the the joint. The negative pressure is there within the hip joint, which increases the stability. So that negative pressure will pull these two bones, the acetabular fossa and the head of the femur, together. So they are more uh, close, and they are more prone for to be together. Okay, so this is the vacuum effect. Then apart from that, as I said, the three major ligaments, the iliofemoral, the pubofemoral, as well as the ischiofemoral, three ligaments which help in the stability of the hip joint. And as I said, there are also secondary ligament like the transverse ligament as well as the ligament of head of femur. All these will help in the stability of the hip joint. One is the deep acetabular fossa, then the acetabular labrum, then the vacuum effect, the three major ligaments, iliofemoral, pubofemoral, as well as ischiofemoral ligaments, then the transverse ligament as well as the ligament of the femur. Now coming to the bursas which are related to the hip joint. So what are bursas? Bursas are nothing but the synovial bags lined by synovial membrane and filled with small quantity of the synovial fluid, and they will prevent friction between the bones and the ligaments, between the bones as well as the tendons of the muscles, because the muscles will be contracting and they will be passing over the joint, and if there is no bursa, then they will start having friction with that of the bone, the tendons, and the bone will come in contact, and there will be friction, and there will be actually production of energy, heat, as well as there will be severe pain. So to prevent this, there will be small bags like balloons filled with a small quantity of fluid. These are called as synovial bags or the synovial bursas, which help smooth movement of the tendons of the muscle over the bones and joints. So there are some important bursas again near the hip joint. One is called as the semi-tendinous iliopsoas bursa. As you can remember, there is a very important muscle here which has actually two parts, the iliacus as well as the psoas major. So these two muscles will be called as together as the iliopsoas, which form the floor of the femoral triangle, if you remember, and just behind that is the hip joint. So whenever this muscle contract, below that there is a small bursa. This is called as the semi-tendinous iliopsoas bursa. Then there is bursa near the just below the gluteus medius. Then there is also a bursa below the gluteus minimus, as well as bursa between the maximus as well as the vastus lateralis. All these bursas will prevent friction and free movement, smooth movement at the joints. Okay, so these are some of the important bursas which are present near the hip joint. What is the nerve supply of the hip joint? If you remember, I had told you about the referred pain. If you remember referred pain, when we were discussing the thigh, at that time we were discussed the referred pain. If there is any problem in the hip joint, usually it will be referred to the knee joint, and it seems that the pain is actually coming from the knee joint. Okay, because the same nerve will be supplying both the joint, hip joint as well as the knee joint. So this is called as referred pain, even though actually the problem is in the hip joint. So it seems the patient will be complaining of the pain in the knee joint. Okay, so because the brain cannot differentiate between the pain coming from the hip joint or the knee joint, because the same nerve will be supplying both the joint. So what are the nerves which will supplying both the joint? One is the femoral nerve and the second is the obturator nerve. If you remember, femoral nerve is the nerve of the anterior compartment of the thigh or the extensor compartment of the thigh, and the obturator nerve is the nerve of the adductor compartment of the thigh. So both these nerves will be supplying both the hip joint as well as the knee joint. So you can see the referred pain, and you should remember that both these joints are supplied by both the femoral nerve as well as the obturator nerve. Apart from these two nerves, hip joint is also supplied by the accessory obturator nerve, nerve to quadratus femoris, as well as the superior gluteal nerve. So all these nerves will be supplying the hip joint. Now coming to the arterial supply, I have told you already that there is a small artery called as the artery of the head of the femur, or the ligament of the head of the femur, which will be passing through this ligament. This is nothing but a branch from the obturator artery. If you can see here, this is the obturator artery, and it is giving a branch. This is called as the acetabular branch, or the artery of the ligament of the head of femur. Okay, so this is one artery which will supplying a small part in the head of the femur itself. Then there are two arteries actually, one medial as well as the lateral circumflex femoral arteries. So if you can see here, this is the deep artery of the thigh, also called as the profunda femoris artery, which is a branch from the femoral artery. If you can see here, this is the femoral artery. It is giving a big branch which supply most of the muscles of the thigh. This is called as the profunda femoris artery, also called as the deep artery of the thigh. And this artery will be giving two branches, one on the lateral side, one on the medial side. These are called as the lateral and medial circumflex femoral arteries. Compare this with again with the circumflex arteries around the head of the humerus. Similarly, here also we have two arteries, lateral and medial circumflex femoral arteries. These arteries also supply the hip joint. Along with this, the superior as well as inferior gluteal arteries also supply the hip joint. So in the bracket, I have mentioned these are the main arteries which gives these smaller branches. So obturator artery is a branch of the internal iliac, as well as the gluteal arteries are also branches of the internal iliac artery. And as I said, the medial and lateral circumflex artery are branches of the profunda femoris arteries, which are in turn branches of the femoral artery. So these are the three important arteries: the acetabular branch of the obturator artery, medial and lateral circumflex femoral artery, as well as the superior and inferior gluteal arteries will be supplying the hip joint. They form anastomosis around the hip joint. I can see here there is anastomosis around the hip joint, and they will supply the whole of the hip joint. They form cruciate as well as the trochanteric anastomosis around the hip joint. Coming to the venous drainage is by veins which have similar name to that of the arteries. So these are called as the corresponding veins. There are corresponding veins which will be draining with similar names, will be draining the hip joint. Coming to the movements of the hip joint, they are very similar to that of the shoulder joint, that is flexion and extension, abduction and adduction, medial and lateral rotation, as well as the circumduction. But the range of movement here in case of the hip joint is lesser. That is what you are supposed to remember. The same movements like that of the shoulder joint are there, but the range of movement is much less compared to that of the shoulder joint. Now coming to the muscles which help in the movement of all these movements in case of the hip joint. So in case of flexion of the hip joint, this is done by the muscles of the anterior compartment of the thigh. Anterior compartment of thigh is also called as the extensor compartment of knee joint, that you should remember. So the anterior compartment of thigh is also called as the extensor compartment because it extends the knee, but it also crosses, some of the muscle crosses the hip joint, so they actually do the opposite function, that is the flexion. So the flexion of the hip joint is done by the iliopsoas muscle, the lateral part of the pectineus, the rectus femoris, as well as the sertoris. These are the muscles which help in the flexion. The posterior muscles of the posterior compartment of the thigh are actually the flexors of the knee joint, but they also help in the extension of the hip joint. So the extension is mainly done by the hamstring muscle along with the gluteus maximus muscle. If you remember, gluteus maximus muscle is the anti-gravity muscle which help in the lifting of your body from sitting position to the standing position. So when you sitting, and if you stand from the sitting position, then you are actually extending your thigh. So this extension is mainly done by the gluteus maximus because it is anti-gravity muscle along with the hamstring muscles. Coming to the adduction, as you know, there is a separate compartment in case of the thigh, which is called as the adductor compartment. So all the adductor muscles of the adductor compartment help in the adduction of the thigh. There is no adduction in knee, so there should be adductors of the thigh. So the adductor longus brevis, as well as the non-ischial part of the adductor magnus, gracchalis, as well as the medial part of the pectineus. All these muscles will help in the adduction. Coming to the abduction is mainly done by the muscles which are on the lateral side, especially the muscles like the gluteus medius and minimus. If you remember, the gluteus maximus in the gluteal region is medially placed, but the gluteus medius and minimus are laterally placed. So they help in the abduction of the hip, as well as the tensor fasciae lata, which is already on the lateral side, as well as the sartorius. All these muscles will help in the abduction. As a rule, the muscles which help in the abduction, the abductors as a rule act as medial rotators also. So all the muscles which can help in the abduction also help in the medial rotation. So it's the same muscle, the anterior fibers of the gluteus medius as well as minimus, as well as tensor fasciae lata help in the medial rotation. The lateral rotation is done by the gluteus maximus, piriformis obturator internus, externus gemelli, as well as the quadratus femur. All the muscles of the gluteal region help in the lateral rotation of the hip joint. Coming to the last part of this hip joint is the applied anatomy, the clinical anatomy, or the applied aspects. The first and foremost is the congenital dislocation of the hip joint. So this is especially seen in case of the newborns, where the newborn is born with the dislocation of the hip joint, or it will be after the birth. But this is chronic, and whenever, even if you reduce the hip joint back to its normal position, again it is prone for dislocation. So this is called as the congenital dislocation of the hip joint. Now you can see here, this is the picture showing depicting the hip joint. Here is the hip, the head of the femur, and this is the sternum. So this is normally placed, but sometimes this head of the femur slips from here, from the cavity, the acetabular cavity, but it is not totally slipped. It is partially slipped, and still some of the articular surface is still there in contact with the articular surface of the acetabular. This is called as subluxation. And if the two articular surfaces totally miss each other and they move away from each other, then it is called as dislocation. So you should know the difference between the dislocation, which is complete separation of the articular surface of the two surfaces, and subluxation, where there is partial dislocation of the joint, any joint. Okay, so this is in case of here also the hip joint. The second is the fractures of the neck of the femur. This is more common again in old age, after 55 to 60 years, especially in people who go for the osteoporosis. After 55-60 years, the person will have osteoporosis, and this is most severe in the neck of the femur, and this part will be usually goes for the fractures of the neck of the femur. So especially in case of the old, because of the osteoporosis. Then there is a condition called as the cox vara. So what is cox vara? So if you know the angle between the axis of the shaft and the neck, it is almost 120 to 125 degrees. And if this angle decreases, then it is called as the cox vara. This the cox vara, where the angulation between the shaft of the femur and the neck is decreased. So this is called as the cox vara. And if it increases more than 140 degree, then it is called as the cox valga. Cox valga and cox vara. Cox vara is decrease in the angulation between the neck and the shaft of the femur, and if there is increase in the angulation, then it is called as the cox valga. Then there is a condition called as the Perthes disease. Again, this is congenital abnormality, where the head of the femur start degenerating, especially this part start degenerating. That leads to severe pain, deformities, and decrease in the movement and whatnot. So this is called as the Perthes disease. Then the tuberculosis, if it is in the bones, then it is usually common in case of the hip joint. Then this joint is also prone for osteoarthritis, especially again this in case of old age. This joint, hip joint as well as the knee joint, are more prone for osteoarthritis, inflammation of the joints. The stiffness of joint, especially in case of rheumatoid arthritis, so where there will be a severe stiffness, especially called as the early morning stiffness. And again you can see this will be in case of the hip joint, is more common in case of the hip joint as well as knee joints. Then there is also a condition called as the neuropathic joint, and there is one more important thing called as the Shinton's line. This is Shinton lines is actually to trace if there is any fractures or dislocation of the uh, femur or not. So Shinton line is a line which extends from the superior ramus of the pubis and over the upper border of the obturator foramen, and it continues over the neck of the femur as a continuous line. This is the it will be a continuous line over these 3 points on the ramus of the pubis, superior ramus of the pubis, on the obturator foramen, upper border of the obturator foramen, then it will continue on the neck of the femur as a continuous line, arch line. But if there is any fracture or dislocation, then this line discontinues. If you can see here it is drawn here, then it is not in continuation with that of the neck of the femur, so it is discontinued. So this indicates that there is fracture or dislocation of the hip joint. Okay, so these are some of the important applied aspects related to the hip joint. Now we'll try to discuss the knee joint, a very important joint, the knee joint. The knee joint is the largest and the most complex synovial joint in the body. So this is the largest joint as well as the very complex synovial joint. So this joint is compound and complex synovial joint consisting of almost 2 to 3 types of joint. One is the condylar joint and the saddle joint. If you remember, this is the classification, and here is the synovial joints. Within the synovial joint, this is involving 2 to 3 types within its own type. One is the cellular or saddle type of joint, second is the bicondylar or condylar joint, and the third is the hinge joint. So all these are included within this joint. That's why it is a very complex joint as well as a compound joint. So there are two important joints within this joint. One is the two condylar joints between the condyles of the femur. These are the two condyles of the femur articulating with the two condyles of the tibia. So this is also called as tibio or femorotibial joint, because there is articulation between the femur and the tibia, between the two condyles of the tibia and the femur. So it is called as the femorotibial joint. And there is also a joint between this as well as the patella in the front. So it is articulation between the patella and the femur. So it is called as the femoropatellar joint. This is the saddle joint which will be present here. That will be called as the femoropatellar joint between the patella and the femur. And there is bicondylar joint between the two condyles of the femur as well as the tibia. So these are the joints which are included within this. Coming to the articular surfaces, what are the articular surface? As we have already seen, it is the articulation between the two condyles of the medial and lateral condyles of the femur with the medial and lateral condyles of the tibia. So this is the articulation between the condyles of the tibia and the femur. Along with that, there is also a patella which also come in articulation, which comes in contact with this joint, and it is also an articular bone here. So patella, the articular surface of the patella also articulate with this two bones. So there is no role of the fibula in this joint. So you should remember, fibula will not articulate within the knee joint. So it is just between the femur as well as the tibia as well as the patella. Okay. So these are the articular surfaces of the three bones: the medial lateral condyles of the femur, the medial lateral condyles of the tibia, as well as the articular surface of the patella. So these articular surfaces are covered by articular cartilage. So here, if you can see here, it is shown in bluish color. This is called as the articular cartilage, also called as the hyaline cartilage. So it has a peculiar arrangement of this articular cartilage. If you see on the condyles of the femur, so it will be much more thicker at the center compared to the periphery. So it is much more thicker in the center compared to the periphery. So it, as you go to the periphery, it decreases in size. Here also you can see, so it decreases in size when it goes to periphery. Just opposite is the articular cartilage on the tibia. If you see here, the tibia is flat, almost flat. The articular surface is totally flat. So this joint becomes very unstable joint, because here there is the condyles which are rounded, and the other articular surface should be concave, but it is not so. It is almost flat. So this becomes opportunity for the dislocations. So to increase this concavity, the articular cartilage at the center here will be thinner, and at the periphery it will be thicker. So there will be increase in some concavity within this the articular surface of the two condyles of the tibia. So the articular cartilage here, if you can see a small thin line, it will be thinner at the center and thicker at the periphery, just opposite to that of the condyles. In the condyle, it will be thicker at the center and thinner at the periphery. So this will increase the concavity. Along with that, the shallowness is also decreased by the presence of something called as the, again, fibrocartilage structure called as the menisci. So they, if you can see here again the picture, so these menisci, again, they increase the concavity of the tibia. So now this is much more better stabilized compared to a flat surface. So the menisci also increase the concavity of the tibia. One is the articular cartilage itself, then the presence of the menisci. If you see the tibia from above, this is how it looks like. These are the two menisci. This is the medial menisci, larger one, and the lateral menisci, small one. And in between, this area is called as the intercondylar area. This is the intercondylar area between the two condyles of the tibia. If you see from above, this is how it looks like. So there are some important structures which are attached from anterior to posterior. This is the anterior part, and this is the posterior part of the tibia seen from above. So this is the tibial tuberosity, which will be in the front, where the ligamentum patellae will be attached. So here, this is the space between the two condyles. This is called as the intercondylar area, and there are some structures which are attached from before backward. There are almost 6 structures which are arranged from before backwards. The first structure is the anterior horn of the medial meniscus. If you can see here, so this is the medial menisci, and here you can see the anterior horn that will be attached actually here to this part. So this is called as the here will be the first attachment will be the anterior horn of the medial meniscus. And the second structure which is behind that will be the attachment for the anterior cruciate ligament. We will talk about this cruciate ligaments, very important ligaments within the knee joint, which help in the stability of the knee joint. These are called as the cruciate ligaments. So here will be the attachment of the second structure, which will be attached behind this will be the anterior cruciate ligament. Behind that will be the attachment for the anterior horn of the lateral meniscus. This is the lateral meniscus here. So here will be the attachment of the anterior horn of the lateral meniscus. Just behind that will be the posterior horn of the lateral meniscus, and behind that is the posterior horn of the medial meniscus. This is the medial meniscus here. So this will be the posterior horn of the medial meniscus, and behind that is the posterior cruciate ligament. The most posterior structure which is attached in the intercondylar area will be the posterior cruciate ligament. So these are the 6 structures which are arranged from anterior to posterior side in the intercondylar area. Now coming to the knee joint, as I said, knee joint, because the surfaces, the articular surface of the condyle are of the femur are much more rounded, and the condyles of the tibia are almost flat. So this joint becomes a very unstable joint. So to stabilize this joint, then there should be more ligaments. So there are almost 13 ligaments which help in the stability of the knee joint. So what are those? So first we'll just name them, later we'll discuss them in detail. The first one is the capsular ligament itself, then the ligamentum patellae. So here you can see here the synovial membrane, around that will be the capsule, outside that will be the capsule around the whole of the knee joint, and here in the front you can see the patella ligament. So patella ligament is in the front. If you remember, the quadriceps femoris get inserted to the base of the patella. Base of the patella is above, and from the apex of the patella it continues down as patella ligament getting inserted to the tibial tuberosity. This is called as the ligamentum patellae. Then there is tibial collateral ligament, then fibula collateral ligament, coronary ligament, oblique popliteal ligament, arcuate popliteal ligament, anterior cruciate ligament, posterior cruciate ligament, transverse ligament, meniscofemoral ligament, medial meniscus, as well as the lateral meniscus. All this structure help in the stability of the knee joint. So there are 13 ligaments which help in the mainly in the stability of the knee joint. Now we'll try to discuss each of them one by one. The first thing is the synovial membrane itself. So as I said, like all the synovial joints, this is also lined by the synovial membrane. Within the cavity of this knee joint, from outside we have the fibrous capsule, and inside of that will be inside surface of the fibrous capsule will be lined by the synovial membrane everywhere except at the articular surfaces. On the articular surface, this synovial, if you can see here, this is the synovial membrane. It covers the whole of the knee joint as well as the spaces, but it doesn't go over the articular surface because this articular surface will be lined by the articular cartilage. So it ceases at the periphery of the articular cartilage. And this synovial membrane will continue above into a bursa which will be connecting with the knee joint. This is called as the suprapatellar bursa. We'll discuss about this bursa again in detail when we discuss the bursas itself. Coming to the tibial collateral, here you can see here this is the fibrous capsule covering the whole of the knee joint. This is the fibrous capsule, and in the front we have the patella ligament, and inside will be lined by the synovial membrane except at the articular cartilage. So here till here it will come, and above this here will be the articular cartilage itself. So it will not be on the articular cartilage. Coming to the next ligament, that is the tibial collateral ligament. In this picture, if you see here, it has not been shown actually, so that's why I have marked here. This is the tibial collateral ligament. So this is said to be morphologically, it represents the detached part of the tendon of the ischial part of the adductor magnus. If you remember, the adductor magnus has a very big insertion into the linea aspera of the linea aspera, and it continues all the way up to this tubercle here. This is called as the adductor tubercle. So this tendon begins from this adductor tubercle from the medial epicondyle and runs down to the medial condyle of the tibia as well as the shaft of the tibia. That's why it is said to be the degenerated tendon of this adductor magnus. So adductor magnus will come till here, adductor tubercle, and it will stop. And this tendon will begin from here and extend all the way up to the shaft of the tibia. So this is said to be a degenerated tendon of the adductor magnus muscle. It has two parts, superficial and deep parts. As I said, above it will be attached to the medial epicondyle of the femur, and below it will be attached to the shaft, medial condyle as well as the shaft of the medial side of the tibia. Coming to the next ligament, that is the fibular collateral ligament. You can see on the other side, on the lateral side, this is the ligament. This is called as the fibular collateral. The tibial collateral ligament will be on the medial side, and the fibular collateral ligament will be on the lateral side where the fibula is present. So that's what it is called as the fibular collateral ligament. So here this ligament is also said to be a degenerated tendon of a muscle called as the peroneus longus. Peroneus longus is a muscle of the lateral compartment of the leg. There are two muscles, peroneus longus and the brevis, in the lateral compartment of leg. The peroneus longus is a bigger muscle which take origin from the upper part of the fibula. So above this, this tendon, if you can see here, this tendon is present. So this is said to be the degenerated part of the peroneus longus muscle. So this ligament will be running from the lateral epicondyle of the femur, and it will go all the way down to the head of the fibula, or to this to a process here. This is called as the styloid process of the fibula. So it extends from the lateral epicondyle of the femur and it goes to the styloid process of the fibula. Then we have the one more ligament called as the oblique popliteal ligament. If you remember, the semimembranosus will be getting inserted. Semimembranosus is a muscle of the posterior compartment of the leg, which is also of the thigh, which is also called as the hamstring compartment of the thigh. So this muscle will be getting inserted to a groove on the medial condyle of the posterior surface of the medial condyle of the tibia. There is a small groove here. This is called as the groove for the semimembranosus. So this muscle semimembranosus will be getting inserted to this groove of the semimembranous area. Along with that, it gives some expansion. This is called as the oblique popliteal ligament. So it is an expansion derived from the insertion of the semimembranosus. This oblique popliteal ligament will extend upwards and laterally. If you can see here, it will be extending upwards and laterally from the posterior surface of the medial condyle of the tibia to the lateral part of the intercondylar line of the femur. So it is almost on the attached to the fibrous capsule. Okay, so it blends with the posterior surface of the fibrous capsule, and this posterior surface of the fibrous capsule will form the floor for the popliteal fossa. So this will be this muscle, this ligament will be oblique popliteal ligament will be also form the floor of the popliteal fossa, and because it in the floor of the popliteal fossa, so it is pierced by middle genicular vessels as well as nerves. Now coming to one more ligament of the knee joint, that is called as the arcuate popliteal ligament. This ligament is not shown here in this picture, but you can imagine it looks like similar to this ligament here. It is Y-shaped fibrous band which extends from the styloid process of the fibula. Fibula is on the other side, on the lateral side. This view is from the medial side. Okay, so here is the fibula. So from this styloid process of the fibula, there is a ligament which extends above. Its posterior band arches over the tendon of the popliteus and is attached to the lateral condyle of the tibia, and the anterior band is deficient, which passes deep to the fibular collateral ligament, and it is attached to the lateral condyle of the femur. So this is how the arcuate popliteal ligament is present. Then there is also a very important ligament, as I said before. These are called as the cruciate ligaments. There are two cruciate ligaments, anterior and posterior cruciate ligament. If you see here in this picture, again this is the picture, coming back to this picture. So this is the anterior cruciate ligament and this is the posterior cruciate ligament. So these are the two cruciate ligaments which are very important in the stability of the knee joint. They are called as cruciate because they cross. If you see here, this is the anterior cruciate ligament crossing and going behind. The posterior cruciate ligament from behind it is coming forward. So they cross each other. So that's why it is called as crossing ligaments or cruciate ligaments. These ligaments, if you see, these are intracapsular but extrasynovial. So if you here will be the femur, and this whole joint will be covered by fibrous capsule from outside. But if you see, this is the this pinkish or brownish structure which is shown here. This will be the synovial membrane. If you see the synovial membrane, it is covering the whole of the knee joint cavity except it comes all the way in the front and it tries to keep these two ligaments outside. So even though they are intracapsular within the capsule, but they are extra synovial. They are not within the synovial cavity, so they are extra synovial. That is how they are placed. They are also they are named as anterior and posterior according to their attachment to the tibia. So even though the anterior cruciate ligament go behind and get inserted to the posterior part of the fibula, the femur, and the posterior cruciate ligament, even though it takes origin from the posterior part, we cannot say origin. We should say always say for the ligaments it will be attachments. Okay, so it will be attached on the posterior part of the intercondylar surface of the tibia, and it comes anteriorly and get again attached to the anterior part of the femur. So these are called as anterior and posterior depending on the attachment to the tibia. So this is attached anterior to the tibia, so it is called anterior. This is attached posterior to the tibia, so it is called as the posterior cruciate ligament. Both are very important ligament, as I said, because they become taut at extreme flexion and extension of the joint. So as I said, because this joint is very unstable joint, because this tibia is almost flat, so the condyles can easily slip. So to prevent this slipping, especially in extreme movement, these two ligaments prevent extreme movements like extreme extension as well as the extreme flexion of the knee joint. These ligaments are actually developed from the posterior part of the primitive intercondylar septum. Coming to the anterior cruciate ligament, as you can see in this picture, if you remember, go back to this intercondylar surface. So here is the attachment of the anterior cruciate ligament on the tibia. So below, attached to the anterior part of the intercondylar area of the tibia, in between the anterior horns of the medial and lateral meniscus. If you can see here, these are the two horns of the medial and as well as lateral meniscus, and between them will be the attachment of the anterior cruciate ligament. If you can see here in this picture again, so the two condyles are here and in between is the anterior cruciate ligament. Then this cruciate ligament, as I said before, it will go back and get attached to the posterior part of the medial surface of the lateral condyle of the femur. If you can see here, this is the lateral condyle because it is near towards the femur, so that's how we can identify this is the lateral condyle, and this tendon is going toward the medial surface of this lateral condyle and getting attached to that part behind. What is the function of this anterior cruciate ligament? As I said, these cruciate ligaments are very important. So what is the function? So one is it binds the two bones together. So it will connect these two bones and they will keep the two bones together. The femur as well as the tibia are kept together by the presence of this cruciate ligament, especially the anterior cruciate ligament. Then it also prevents hyperextension, as I said, because it is attached in the front here, and then on the femur it is attached behind. So whenever it tries to extend, up to a certain extent you allow, but after that it becomes taut whenever you try to hyperextend. So it prevents hyperextension of the knee joint. It also prevents forward displacement of their tibial condyles, and the tibial condyles, if they want to, on the stable femur, if the tibial condyles try to slip in the front, then it is prevented by this anterior cruciate ligament. In extension, it forms vertical axis around which the femur rotates in locking and unlocking. So whenever you know the locking during of the knee joint as well as unlocking, the femur as well as the tibia come in almost in the same angle. So whenever they come in almost in the same angle, then this ligament will actually act as the axis for the two bones to rotate on that, so that there can be locking as well as unlocking. So for unlocking and locking, the axis is formed by this ligament. This is about the anterior cruciate ligament. So these are some of the functions of the anterior cruciate ligament. It binds the two bones together, it prevents hyperextension, it prevents forward displacement of the tibial condyles, as well as in case of extension, it forms the axis, vertical axis around which the femur rotates on the tibia. Coming to the posterior cruciate ligament, this is attached to the posterior part of the intercondylar area. If you can remember, so here is the attachment of the posterior cruciate ligament. So it is posteriorly attached, so it is called as the posterior cruciate ligament. But it comes forward and get attached again. If you can see here, come forward above and it get attached to the lateral surface of the medial condyle of the femur. So it will come in the front. If you can see here, it is coming in the front and get attached to the lateral surface of the medial condyle, because again the fibula is on the lateral side and the tibia is on the medial side, so this should be the medial condyle. So it is getting attached to the medial condyle on the lateral surface. What are the functions of the posterior cruciate ligament? This also helps in the binding of the two bones. As you can see, both the ligaments help in the binding of the two bones together, keeping the two bones together. This ligament, apart from that, also prevent backward displacement of the tibial condyle. If you can see here, so this ligament, anterior cruciate ligament, is preventing anterior displacement of the tibia over the stabilized femur, and the posterior cruciate ligament prevents actually the posterior dislocation or displacement of the tibia over the fixed femur. Both the cruciate ligaments prevent side to side displacement also. So these ligaments also prevent the side to side displacement of the tibia over the femur. So these are some of the functions of the anterior and posterior cruciate ligament. Coming to the menisci, these are semilunar cartilages you have already seen here. So these are the two cartilages, fibrocartilaginous structures which are present within the cavity of the this synovial joint, that is the knee joint. Menisci are fibrocartilaginous structures which project from the fibrous capsule as incomplete partition. If you can see here, they are not complete. They totally don't divide the whole of the cavity into two, but they are incompletely dividing this space, the cavity of the knee joint, into an upper half as well as a lower half. The upper part will be called as between the menisci and the fibula will be called as the meniscofemoral compartment, and below this there is a small space again below this menisci. This is called as the meniscotibial. Above will be the meniscofemoral and below will be the meniscotibial compartment. These menisci will divide the whole of the cavity into an upper part, meniscofemoral, and below part, that is be called as the meniscotibial compartments. These menisci, as you already seen, there are two. One is medial and lateral menisci. So how do you identify? This is the medial menisci, which is much more larger compared to the lateral one, and this lateral one is much more rounded. So the medial menisci is semilunar in shape, almost half crescent moon shape, and longer anterior-posteriorly. If you can see here, if you measure this anterior-posteriorly, it will be much larger compared to the lateral menisci. So the lateral menisci is almost a circle. It is forming almost a circle. It almost forms 4/5 of a circle. Only a small part is remaining, which if it completes, then it becomes a complete circle. So this is almost a circle, almost forming 4/5 of a circle. Okay, so this is the lateral meniscus and this is the medial meniscus. What is the function of these menisci? Menisci is the puller of the meniscus. Okay, so they make articular surfaces more congruent. If you can see here, as I said, the tibia is a very flat bone on the articular surface, so it has to be congruent, so it has to be made somewhat concave, and that can be done by these menisci. So they increase the cavity of the tibial condyles for better adaptation, as well as they are made more congruent by these menisci. Then they also acts as the shock absorber, because they are present between the femur and the tibia. So whenever you jump from a height, these two bones are prevented from coming and touching each other by the presence of these menisci. So they act also as the shock absorber. They also maintain potential space for flushing synovial fluid to provide nutritional supply to the cartilages. If these two bones come very close to each other, there is no space, and the fluid, the synovial fluid cannot flow through this, and then there will be a deficiency of nutrition to the articular surface, especially the articular cartilage, as well as small part of these bones are also supplied by the synovial fluid. So this synovial fluid will be providing the nutrition to the surfaces, and this can be done by keeping a space between the articular surfaces. The peripheral margin of the menisci are vascular and inner part are avascular. The peripheral margins of these menisci are vascular because they are supplied by the same arteries which are supplying the capsule of the knee joint. And the medial part, they are avascular, so these medial parts will be supplied by the again nutrition from the synovial fluid, and they have the capacity to regrow. And these menisci give an additional nerve supply. Their nerve supply gives an additional sensory function for better stability of the knee joint, because whenever if there is even slight injury, as I said, if you jump from a height, so these menisci also have nerve supply. So if there is any trauma, these menisci will also send an additional sensory impulse, which will give a shooting pain, and immediately you take action. And so hence this menisci with additional nerve supply will give additional sensory function, which again it prevents even small changes within the knee joint. And if there is any change, even small changes, then immediately there will be sensation which will be felt with pain and other things, and then you try to take immediate action. So these are some of the important functions of the menisci. One is they make the articular surfaces more congruent, they increase the concavity of the tibial condyles, they act as this shock absorber, they maintain potential space between the surfaces, they are vascular in the center and avascular in the medial side, and that is supplied by the nutrition from the synovial fluid, as well as they give additional nerve supply to these knee joint, which will prevent even small changes and help in the stability of the knee joint. There are also some small ligaments called the meniscofemoral ligament, which will be attached to the posterior horn of the lateral meniscus. So here is the lateral meniscus, and to the posterior horn of the lateral meniscus is connected to medial condyle of the femur. So it is attached to the medial condyle of the femur by two ligaments, anterior and posterior. Anterior meniscofemoral ligament, which is called as the ligament of the Humphrey, and there is also posterior meniscofemoral ligament, which you are seeing from here. Is the lateral meniscus, and there is a ligament which is running from there to the medial condyle. This is called as the ligament of Risberg. So these are also some important ligaments which help in the stability of the knee joint. They regulate actually the forward movement of the lateral meniscus during extension. Whenever you extend, so this ligament will be actually pulling the lateral meniscus forwards. Apart from that, there are also some small ligaments called as the coronary ligament. Coronary ligament is actually a small ligament which connects the peripheral margins of the menisci to the which attach the peripheral margin of the menisci to the capsule. Part of the fibrous capsule which provides attachment to the peripheral margin of the medial and lateral meniscus on either side. Okay, so this is the capsule, and these are the menisci, and they are connected by this coronary ligament. The transverse ligament, here you can see here, this is the transverse ligament which connects the anterior horn of the medial meniscus. So this is the medial meniscus anterior horn with the anterior margin of the lateral meniscus. Here also you can see in this picture. So there is the transverse ligament of the knee joint. And this ligament is present in almost 40% of the subject, not in everybody, but almost 40% of the subject you can see the transverse ligament. Now coming to the bursae around the knee joint. As I said, the knee joint is a very unstable joint, so it has lot of ligaments as well as a lot of muscles which are acting. So this is also covered by a lot of bursas which prevent the friction between the bones and the tendons of the muscles. So there are around 13 bursae here. Bursae is the plural of the bursa. So there are 13 bursae, 4 in the anterior, 4 in the lateral, and 5 in the medial. So the most important, which are clinically again important, will be the anterior. So the first one is called as the suprapatellar bursa. There is a very important bursa above the patella. So this is called a suprapatellar because it is above the patella and behind this quadriceps femoris. So this is called as the suprapatellar bursa, which communicates with the knee joint. So if there are any changes in the knee joint and if there is any inflammation of the knee joint, then this will also get inflamed, and you can see the pain and redness, everything above the patella. So this is because the suprapatellar bursa will be communicating with this. So if there is any swelling, pain, redness, everything, you can see in case, especially if there is osteoarthritis or rheumatoid arthritis, something like that, at that time you can see as well as feel the increase in temperature and the pain, severe pain and redness, everything above the patella, because this is because of the suprapatellar bursa which communicates directly with the knee joint. The second bursa is subcutaneous prepatellar bursa. If you can see here, this is a prepatellar bursa. It is in the front of the patella, so it is called as prepatellar. Pre means front, supra means above, pre means in front, and infra means below the patella. So all are related to the patella, so they are named according to their position with the patella. The suprapatellar bursa, this is the prepatellar bursa, which is subcutaneous, just in front of the deep to the skin is this prepatellar bursa. This bursa is very important, especially in case of maids. Whenever the maids clean the floor, they clean the floor, at that time they will be kneeling and actually putting their pressure on the knees, and they try to clean the floor. So this bursa are prone to get infected and inflamed. So that's especially in case of housemaids. So that's why it is called as the housemaid knee. Then there are some infrapatellar bursa. One is the subcutaneous bursa and the deep bursa. So this is the subcutaneous infrapatellar bursa. Again, these are also prone for infection and inflammation, especially in case of the clergies. In case of the churches, clergymen, they especially actually pray with kneeling down on their knees, and this will especially inflame the infrapatellar bursa. So that's why it is called as the clergyman's knee, where the subcutaneous infrapatellar bursa will be inflamed. Apart from that, there is also one bursa which is deep inside. This is called as the deep infrapatellar bursa. So if you can see here, deep inside here is the deep infrapatellar bursa, which is also present deep to that. So these are the 4 anterior bursas which are very important: suprapatellar bursa, subcutaneous prepatellar bursa, then we have the subcutaneous infrapatellar bursa and the deep infrapatellar bursa. Apart from that, there are other bursas which are on the lateral and medial side. So on the lateral side, we have a bursa deep to the lateral head of the gastrocnemius. Then we have the bursa between the fibula collateral ligament and the biceps femoris. Then we have the bursa between the fibula collateral ligament as well as the tendon of the popliteus. Bursa between the tendon of the poplite as well as the lateral condyle of the tibia. I don't have pictures for all these bursas. And on the medial side, we have also bursa, 5 bursas. Bursa deep to the medial head of the gastrocnemius. Here is the lateral head and here the medial head. Under both these heads, we have the bursas. Then there is also a bursa called the anserine bursa. Then there is bursa deep to the tibial collateral ligament. Then there is a bursa just below the semimembranosus. Then bursa between tendon of the semimembranosus as well as the semitendinosus. So these are some of the bursas which are present around the knee joint, but the most important will be clinically will be the anterior bursas in case of the knee joint. Now coming to the anastomosis around the knee joint. This we have already discussed in the popliteal fossa, but still just to recall the things. So the knee joint is highly vascular joint supplied by lot of arteries which anastomosis around the knee joint. So what are the arteries? We have already discussed the 5 genicular arteries. One is the superior lateral genicular artery, then we have the inferior lateral genicular artery, then superior medial genicular artery, and the inferior medial genicular artery, and a central artery, which all these arteries will be supplying the knee joint. So these are the branches which are coming directly from the popliteal artery here. So this is the popliteal artery. If you can see here, this is the femoral artery coming from the femoral triangle into the adductor canal, and then it pierces the adductor magnus muscle. This is called as the adductor hiatus, through which this femoral artery from the adductor canal will be passing into the popliteal fossa. So this is the popliteal artery, and these are the 5 branches, genicular branches. Genu means knee, so genicular branches are those branches which are supplying the knee joint. Then apart from that, there is also the descending genicular branch of the femoral artery. If you can see here, this is the femoral artery. So before it passes through the hiatus and become the popliteal artery, it gives a branch. This is called as the descending genicular artery. Then we have the descending branch of the lateral circumflex artery. If you see here, this is the descending branch of the lateral circumflex artery. If you remember, lateral circumflex femoral artery is a branch from the deep artery of the thigh, or the profunda femoris artery. Then we have the two recurrent branches of the anterior tibial artery. If you see here, this popliteal artery will continue down as the posterior tibial artery, as well as it gives a branch. This is called as the anterior tibial artery. So anterior tibial artery will give a branch. This is called as the recurrent branch of the anterior tibial artery. Then the posterior tibial artery also gives a branch. This is called as the circumflex fibular artery. So these are some of the arteries which supply the knee joint. So this is a rich anastomosis of lot of arteries which communicates with each other, and then they supply the knee joint. Coming to the nerve supply, as I said, nerve supply of the knee joint is very important. Especially I had told you about the referred pain. Again, the referred pain is that pain where actually there is a problem in the hip joint, and it is sensed as though it is from the knee joint, because the same nerves will be supplying the hip joint as well as the knee joint. So the brain cannot differentiate between pain from the hip joint and the knee joint, and it misinterprets in the other joint. So this is called as the referred pain. So the nerves which will be supplying both the hip joint and the knee joint will be two, that is the femoral nerve as well as the obturator nerve. So the knee joint is supplied by 10 nerves, 3 branches from the femoral nerve. If you remember the femoral nerve will be giving anterior and posterior division, and the posterior division will be supplying 3 vasti, and from the 3 vasti they will be supplying the knee joint. The vastus lateralis, vastus intermedius, vastus medialis, all will be supplied by the femoral branches, the posterior division of the femoral branches, which in turn supply the knee joint. The rectus femoris branch will be supplying the hip joint. So the same femoral nerve will be supplying both the hip joint as well as knee joint. So these 3 branches are from the 3 vasti muscles which are coming from the femoral nerve. Then 3 branches from the tibial nerve through the superior, inferior as well as the medial genicular nerves. Then 3 branches from the common peroneal nerve. Tibial nerve and common peroneal nerve are branches of the sciatic nerve, and they will be supplying the knee joint. And 1 branch from the obturator nerve. So actually the femoral nerve and the obturator nerve are because of these 2 nerves which supply both the hip joint and the knee joint, you can feel the referred pain. Okay, so these are some of the nerves, the 10 nerves which supply the knee joint. The 3 branches from the femoral nerve, 3 branches from the tibial nerve, 3 branches from the common peroneal nerve, and 1 branch from the obturator nerve. All these nerves will be supplying the knee joint. So it is richly vascular as well as richly supplied by the nerves. So hence the L3, L4, L5 and S1 will control the knee movements, and L3 and L4 regulate the extension, and L4 and L5 will regulate the flexion of this movement depending on the nerves as well as the muscles which they will be supplying. Coming to the movements at the knee joint, there are two important movements. One is the flexion and extension, and there is rotation movement. So rotation movement, which is the locking as well as the unlocking of the knee joint over the fixed tibia. So this is the rotation movement, where we can see the medial rotation of the femur on the knee, actually on the tibia. So this is called a locking, and the opposite movement will be the unlocking of the knee joint. Locking is defined as medial rotation of the femur, as you can see in the picture, medial rotation of the femur on the fixed tibia during terminal stages of extension at the last 30 degrees of extension. When you are extending, you are not only extending the knee joint, but also there is a rotation, medial rotation of the femur over the tibia. So this is called as the locking of the knee joint, which help actually for long standing of the person without spending any energy. So once you stand for a long time, then the knee joint will extend and locks, and then all the muscles will become relaxed, and you don't spend much energy if you stand for standing for a long time. And when you are again flexing the knee joint, first it will unlock, then it will flex the knee joint. So these movements are done by some of the muscles. Especially the flexion is done by the muscles which are present in the posterior compartment of the thigh, which are called as the flexors of the knee or hamstring muscle, that is the biceps femoris, semitendinosus as well as the semimembranosus. Along with that, there are accessory muscles which help in the flexion, that is gracchalis, sartorius, popliteus and the gastrocnemius muscle. Coming to the extensions of the knee are present in the anterior compartment of the muscle, especially the quadriceps femoris, which help in the four muscles, rectus femoris, vastus lateralis, medialis as well as the intermedius. These are the four muscles, quadriceps femoris together, they are called as quadriceps femoris. Those muscles will be helping in the extension of the knee joint. Along with that, there is also the tensor fascia lata, which is said to be the muscle of the anterior compartment as well as the gluteal region. So this tensor fascia lata also help in the is an accessory muscle which help in the extension. Coming to the medial rotation of the flex leg, it will be done by the popliteus muscle, semimembranosus as well as the semitendinosus. Accessory muscles are sartorius and gracchalis. Coming to the lateral rotation of the flex leg, that will be done by the biceps femoris. Coming to the last aspect of this knee joint, the applied aspects related to the knee joint, clinically important features. One is the osteoarthritis. So knee is a very common site for the osteoarthritis, especially in case of old age. Because of the osteoporosis, there will be arthritis also in the knee joint, inflammation as well as severe pain in the knee joint. This is mostly seen in the knee joint. The syphilitic arthritis is also common in case of the knee joint, and the tuberculosis, especially the pyogenic infections, are more common again for the knee joint. Injury to the menisci are present only in the knee joint, so the injuries to the menisci should be in the knee joint itself, and these menisci injuries are also common in case of the knee joint. Injuries to the cruciate ligament, again the cruciate ligaments are present in the knee joint, and whenever there is a displacement of the tibia, I said the cruciate ligaments will be preventing displacement of the tibia over the stabilized femur, and if there are any traumas or something, road traffic accident, something like that, and if there are any dislocation, this is because of the injuries to the cruciate ligaments. Injuries to the collateral ligament, this is also seen when there are any trauma to the knee and displacement of the tibia and the fibula. Injuries to the collateral ligament. And bursitis, because there are a lot of bursas around, so they get inflamed, and I named some of them, the housemaid knee as well as the clergyman's knee. So these are the inflammation of the bursas, which is called as bursitis. Collection of the fluid in the knee joint is also common, because whenever there is bursitis, inflammation of the knee joint because of any reason, osteoarthritis, rheumatoid arthritis, or something else, then it all leads to collection of increased collection of fluid in the knee joint. Whenever there is inflammation, there will be collection of the fluid, increased production of the synovial fluid. Then there are two conditions called as the genu valgum as well as the genu varum. Genu means knee, so genu valgum as well as the genu varus. So if you see here, this is called as the genu varus. When the knees are bowed up and they are outside, they are diverted outside, then this is called as the knock knee. This is called as the bow knee. Okay, so whenever you see the knees are direct upwards, then it is called a bow. Looks like a bow. Just opposite is the genu valgum, where the two knees are directed towards each other and they will be knocking each other. So this is called as the knock knee. They knock in the front as well as knock to each other. So they are called as the knock knee, and these are called as bow knee because they look like a bow and arrow, so it looks like a bow. So that's what is called a genu varum is also called as the bow knee, and the genu valgum is also called as the knock knee. And fractures of patella are also common whenever there are any injuries to the knee joint. So these are some of the important applied aspects related to the knee joint. Now coming to the ankle joint. This joint is also called as the talocrural joint. This joint is a hinge type of synovial joint. This is also a synovial joint, but it is hinge type. We have seen already the classification of the joints, and in case of synovial joint, there is a type called as the hinge type. So this is a hinge type of joint. The articular surface is between the lower end of the tibia. This is the lower end of the tibia with its medial malleolus. This is the medial malleolus, and the lateral malleolus of the fibula, which will be articulating from above, and the from below. This is the talus. So the inferior transverse tibiofibular ligament will be present here. So all these three bones, the tibia as well as the medial malleolus, the fibula with its lateral malleolus as well as the talus, will be articulating with each other. So these will be the articular surfaces. Below, as I said, will be the wedge shaped talus bone here. Okay, so these are talus bone here, which will be articulating with the tibia as well as the fibula as well as a ligament which is present there. This is called the inferior transverse tibiofibular ligament. Stability of the joint. This is a very stable joint, and it is maintained by interlocking of the close interlocking of the articular surfaces. So these bones are in very close proximity to each other, and they will interlock each other. The close interlocking of the articular surface of the three bones, and strong collateral ligament on the sides, as well as the crossing of the tendons, especially the long tendons which are coming from the anterior compartment of leg as well as the posterior compartment of leg. They will be all crossing. 4 in the front, which are coming from the anterior compartment, and 5 from the behind, coming from the posterior compartment of leg. All will stabilize this ankle joint. There are also ligaments which help in the stability of the knee joint. One is the fibrous capsule itself, then the deltoid, or also called as the medial ligament, as well as the lateral ligament. Medial ligament is also called as the deltoid ligament. Blood supply to this ankle joint is by anterior and posterior tibial arteries as well as the peroneal arteries. So all these are branches of the popliteal artery. Popliteal artery divides into an anterior tibial artery and a posterior tibial artery, and the posterior tibial artery also gives a branch called as the peroneal artery. Nerve supply is by the deep peroneal nerve as well as the tibial nerve. Tibial nerve will be supplying as well as the deep peroneal nerve, which is also called as the anterior tibial nerve, will be supplying the ankle joint. Coming to the movements of the ankle joint, there are two types of movement. One is called a dorsiflexion and the plantar flexion. Dorsiflexion is such a movement in the foot where you lift the foot upwards. and try to show the sole in the front. So that is called a dorsiflexion, and the plantar flexion, where you allow the ankle joint to drop the foot, that is called as the plantar flexion. So the dorsiflexion is done by the muscle in the anterior compartment of leg, the long muscle of the leg. This is called as the tibialis anterior, which is the principal muscle in dorsiflexion, and there are accessory muscles like the extensor digitorum longus, extensor hallucis longus, as well as the peroneus tertius. The plantar flexion will be done by the muscles in the posterior compartment of the leg, that is the gastrocnemius and the soleus, which will be actually inserted to the calcaneus bone, and whenever they contract, they help in the plantar flexion. Then there are accessory muscles like the plantaris, tibialis posterior, flexor hallucis longus, as well as the flexor digitorum longus, all muscles in the posterior compartment of the leg. So these are the muscles and these are the movements. There are only two movements here at the ankle joint, dorsiflexion as well as the plantar flexion. Then coming to the subtalar joint. So if you see here, this is the picture showing the different joints here. This is the tibia and the fibula at the lower end, and here you can see the talus, and here is the calcaneus. So the joint between the tibia and the talus, this is called as the ankle joint, and this is the talus, and between the talus and the calcaneus there is a joint, this is called as the subtalar joint. So these two joints are different and the movements at these joints are different, so you should remember. So this is the ankle joint between the tibia, fibula and the talus, and the subtalar joint between the talus and the calcaneus. As the name indicates, subtalar, so it is below the talus. So this subtalar joint is also called as the talocalcaneus because it is articulating between the talus and the calcaneus. Okay, so this is a plain type of synovial joint. So if you remember the classification, in case of the synovial joint, this was the last type, the plain synovial joint. So this is articulation between the bones, talus as well as the calcaneum. The inferior surface of the body of the talus, and the convex facet on the middle 1/3 of the superior surface of the calcaneum. So this is the two articular surfaces which are facing each other. What are the ligaments which help in the stability of the knee joint? One is the fibrous capsule, because this is a synovial joint, so it has to have a fibrous capsule. Then we have the lateral and medial talocalcaneal ligament. If you see here, there is the lateral talocalcaneal ligament, and on the other side will be the medial talocalcaneal ligament. So there is a small ligament here, if you can see here, which is cut here. Actually it is not shown completely, it is cut. This is the talocalcaneal ligament. This is on the lateral side, on the medial side will be the medial one. Then there is interosseous talocalcaneal ligament, which is thick as well as very strong ligament, as well as the cervical ligament. If you can see a deep inside, you can see here, this is the cervical ligament. These are the four ligaments which help in the stability of this subtalar joint. So the four ligaments are fibrous capsule, lateral and medial talocalcaneal ligament, interosseous talocalcaneal ligament, as well as the cervical ligament. These are the four ligaments which help in the stability of the subtalar joint. Why this joint is so important? Because there are two important movements which are taking place in this joint. One is called as the inversion of the foot and the eversion of the foot. So these are two important movements which will be taking place at the subtalar joint, inversion and eversion. If you remember, at the ankle joint we have the plantar flexion and the dorsiflexion, and in case of the subtalar joint we have the inversion and eversion of the foot. So there are different movements at these two joints, ankle joint and the subtalar joint, even though they are very close to each other. So this is all about the hip joint, the knee joint, then the ankle joint, as well as the subtalar joint. So if you have any doubt regarding any of these joints, you can always write to me and I will try to answer. Thank you.